I'm Michael Pearson. This is The Human Condition. What we're doing today is talking about eye movements. This class was requested by the learners in my group. These are largely practicing psychologists and therapists of all types that have degrees like social worker or licensed marriage and family therapist, PhDs in psychology. These are master level and PhD level therapists that treat people with mental health. And they've asked me to go through, most of them also do EEG and ERP, and they've asked me to go through some of the eye movements and the neurology of eye movements, because that's not always a part of their curriculum. So this one's for you guys. And for anyone else that wants to understand the basic eye movements and how we break them down in neurology, this is going to walk you through some of them. It's not a comprehensive course, but it's an introduction to the eye movement types, so you can understand where and how they work in the brain, what areas of the brain are elicited and recruited when you do this evoked potential, which is what it is. Anytime you do something, it's an evoked potential. So I would like to start with the VOR, or the vestibulo-ocular reflex. Now, the vestibulo-ocular reflex is characterized by when the head is moved through space in a rotational fashion. Usually, we're talking about a rotational fashion. There is fluid that moves across these hairs, and these hairs are called kinocilia inside your inner ear. So you've got these three semicircular canals in each ear, and they're really tiny. They're like as big as your fingernail, and they're oriented in different places in your inner ear. You have the horizontal one, which is almost completely flat, but not quite. It's tilted up a bit, about 30 degrees. We have the anterior canals, which are oriented kind of like the St. Louis Arch in this fashion, and then the posterior canals that are oriented in this fashion. And so you can imagine that they stand up like the St. Louis Arch, and that's what they look like. The semicircular canals are oriented in 3D so that your two ears work together. If you look at your typical horizontal canals, which are oriented, like a St. Louis Arch pointing out where my fingers are, the peak of the arch is this way, and you turn it down like this. And remember, it's only as big as your pinky, and it's pointed like this. And in my natural posture, it's up like this. So to get it the right level, we have to drop the head about 30 degrees. So once we get to this place, when I turn my head, I'm activating the horizontal canals. When I turn to the right, my right, over here, I will activate the right side and inhibit the left side. And what that will do is create what we have called a doll's eye reflex. And so as the inner ear on the right and the inner on the left send messages to the cerebellum, the midline of the cerebellum will then integrate that information and send it up to the eyeballs and make the eyeballs go opposite the head motion. So you get essentially this. That's a VOR, a vestibulo-ocular reflex, or a doll's eye reflex. Now, it's very simple to look at the doll's eye reflex in the horizontal because of the way the canals are oriented. Now, again, if the person's upright and sitting, you need to orient them like this. If they're laying down, they need to have their head tilted up to a certain degree if they're laying supine on their back. So it's not quite straight on normal posture. It's about 30 degrees tilted forward. But don't forget, there's other canals. So as I illustrated, there's the horizontal canals, but there's also the anterior canals and the posterior canals. So if you've got an anterior canal on one side and a posterior canal on the other, when you turn your head, there should be a line. So hopefully you can see that when I turn my head 45 degrees, hopefully these things will be aligned. Now realize that skulls are not symmetric. So it's very possible that a person may have a skull that is not quite symmetric, and that's one of the foundations of our personality. It contributes to who we are. It contributes to how good we are at sports, and so we may not have lined up perfect inner ears, and that's part of what gives us the color and style of our lives. It's one of the many things that contributes to our unique individuality, and we can't correct it because the skull is fixed. Well, maybe over the course of plenty of months or years of cranial work, you could correct it, and certainly in chiropractic and in osteopathy, we do cranial work, and we may be able to correct those things. But largely, these are oriented inside the bony labyrinth and essentially bone or cement, and it's hard to change. But it is possible they could change. So in any case, If I've got an anterior canal and a posterior canal, and I turn my head, they should get lined up. So hopefully you see that those are lined up. So when I turn my nose to my right 45 degrees and I line up my posterior and anterior canal, when I tip my head forward and tip my head back, something happens to my eyes. Can you see what happens to my eyes? When I tip my head back into my right, which is, of course, we've got to start with neutral, turn my nose to the right, and then tilt back, activating my right posterior canal, which is this one waggling. My eyes go down, don't they? And that's just so I can follow a target. It's simple. It's evolution. And when my if I activate my anterior, this is my left hand. I'm wearing my watch on my left hand, and so this is my left anterior canal. As I lean forward, what do my eyes do? They stay on the target and they go up. So just to review, when I do a right posterior canal activation back into the right, my eyes go down and left. So posterior canal activations drive the eyes down and away. Anterior canal activations drive the eyes up and toward that canal. Because remember, when I go forward, activating my left anterior canal, my eyes go up and toward that canal, which is this left anterior canal. And they're yoked together such that you get this up, down, up, down. Otherwise, my eyes would stay fixed in my head and they would not move as if they were just taped, in place. And that's not a VOR. So likewise, it goes the same the other way. If this is my anterior canal and this is my posterior canal, my right hand, my left hand, and I line them up by turning 45 degrees off center, hopefully those hands will be aligned. And yep, here we go. They're almost aligned. Let's see if I can do this, test of my own brain. And now I've got a posterior canal, which is in the back here. On my left side, I go backward, and where my eyes go? Down. And to my right. Down and to my right. And when I go forward, they go up and toward that canal. So here's the active canal. Here's the active canal. And so that's the process. So that's all 6 of the canals. And so those are vestibulo-ocular reflexes. So it's pretty difficult to test, unless you're thinking really hard, the semicircular canals that are anterior and posterior. But the horizontal canal is frequently done very easily with the doll's eye reflex, where you have the patient look at the operator or the doctor, and then you just turn their head and say, "Keep your eyes on me." And usually they can do that. And the neat thing is, if you put goggles on them so that they're in the dark, this reflex will operate without any vision. You can be completely blind in the dark, and when you just turn the person's head, you'll see the eyes stay straight ahead like that. And the same goes for if you have them in infrared goggles, which we have, infrared goggles that can see in the darkness, and you have them completely in the dark. Their eyes can't see a thing, and you do this thing that I just did with you, and you do this, you'll see the eyes do exactly what mine just did without any visual stimulus. That same thing. So that's a VOR. It's a function of the midline cerebellum. It receives information from the semicircular canals, from the kinocilia, right? They get bent by the fluid, and as they bend, they send neural signals down as receptors to the cerebellum. The cerebellum essentially takes those and sends them to the eyes and directs the eyes opposite the motion. So whatever the motion is of the head, the eyes go opposite. So it's an assessment of the cerebellum and also of the eyeballs and also of the inner ear. The next one is called the COR, which is really not based on the movement of the fluid in the inner ear. It's called the cervico-ocular reflex versus the vestibulo-ocular reflex. Vestibular means the vestibulum, or the inner ear to the eyes. Cervico-ocular means neck to eyes. And so normally, according to Lee and Z and other textbooks, you're supposed to have about 90% of your input is supposed to be from your vestibular center, your ears, and about 10% comes from your neck. But when you're a professional athlete, like a figure skater or a hockey player or somebody that does a lot of spinning, you tend to go the opposite, and you tend to turn off and shut down. Or a professional diver, for example, Olympic divers, you tend to turn off your vestibular system and rely on your proprioceptive system 90%. So you flip it; it becomes 90% mechanoreception and proprioception from joint mechanoreceptors, and only about 10% roughly of inner ear input, because you have to largely ignore the inner ear or you'll throw up or get disoriented. So people learn to inhibit their vestibular system, and that way they can spin super fast in figure skating, or they can spin around like crazy while diving and know when to open their arms and unfold and hit the water right, because they've got to know how to do that. So that's called the COR, the cervico-ocular reflex. So the vestibulo-ocular reflex should work if I was sitting in a chair, and let's say that I'm sitting on a stool that rotates, and I'm sitting on a stool that rotates, and so if I were to have my head and trunk fixed together by like just holding myself, or holding my head fixed to my trunk, and you rotate me at the trunk, or you rotate the chair at my butt, then I'm gonna have a good doll's eye reflex if you ask me to look ahead, and I'll have this. Now realize that there's an end to the VOR reflex and the COR reflex. There's an end to it, and so it becomes nystagmoid. You get this bit of a nystagmus where the person has to have a fast phase and a slow phase depending on which way they're going. So we look for that and we measure it. And there's all kinds of ways to measure pathology with devices that can record this, and we call that a vestibular testing, and we also call it VNG, video nystagmography, which is the gold standard in neurology for measuring vestibular disorders. So the difference between a vestibulo-ocular means that your semicircular canal fluid moved inside your head, but your neck proprioceptors didn't move. So a pure way to test the inner ear while doing this would be to spin the whole body on a chair. So the whole body is motionless except for it pivoting around a core, around an axis, and that would move the semicircular canals. Once you move the neck bones and the neck joints and the neck receptors from relative to the trunk like this, then you're getting the neck too. And so that's the cervico-ocular reflex. The cervico-ocular reflex is neck to eyes. So that one also works in the same way, and that when you look at a target and you turn your head, you should keep your eyes on the target. So some doctors will do vestibulo-ocular by making sure the patient doesn't move their neck. They move the whole chair, and then they do the cervico-ocular by turning the head and neck. And that's how they differentiate the two of them. The optokinetic is the next test. We're looking at what's called the optokinetic, and it's often written or abbreviated OKN or OPK. Those are the two ways to write it. It's often written OKN as an optokinetic, or OPK for optokinetic. And this is where you see flashing checkers go by. So if you were to see like a fence post go by, or some kind of a I'll draw it for you. If you were to have some kind of a tape, and we often use old wallpaper and stripes. So we're just talking about stripes, right? We're just talking about stripes. So let's say you had some kind of a visual representation that was all filled in, and then it was open and then all filled in, and it represented bars or stripes, just like this. Very simple, very simple. And you moved it past someone's visual field. If you moved it past someone's visual field, what do you think you would see their eyes do? You would see their eyes go tuk, 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 tuk. And so that is nystagmoid. It's a nystagmus type of movement. It's not a nystagmus that's pathological. It's actually physiological because you want it and it's supposed to happen. What you're doing is you're tracking an object as it goes by. You're fixating on one of those bars. And as the bar goes by, at some point your eye says, it's too far. My eye can't go that far. My head can't turn that far. And you refixate back with a fast move, a fast eye movement. It's called a fast phase eye movement. And then you begin the slow phase eye movement, which is tracking again. And so that happens in the VOR, it happens in the COR, and it happens in the optokinetic. Now, obviously, the optokinetic is the head is still, and the target is moving in front of the subject. So if I'm the patient and I'm holding still, my head is not moving. And sometimes you even have to have the person hold their own head still, or you might have to hold it still for them. And then you move the target across and they watch it and they go tick, 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 tick. And so you're supposed to see this fast and slow phase movement. Just like when you have somebody do the vestibulo-ocular reflex and you turn their body, but not their neck. At some point, if you turn it far enough, they're going to go tick, 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 tick. You can't see it when I just do this much of an arc because my eyes don't start to do the nystagmoid movement. But again, the VOR, the COR, and the optokinetic is all going to give you a nystagmoid movement if you move the person or the body or the target far enough. And you'll start seeing those eyes go have a fast phase and a slow phase. The slow phase is tracking and the fast phase is refixation. Now, when we assess these, all eye movements are stopped by the cerebellum. So very generally, the process of stopping an eye movement is always done by the cerebellum. The initiation of eye movements is done by a different thing. And usually for the vestibulo-ocular, it's initiated by the cerebellum. For the cervico-ocular, it's initiated by the cerebellum. For the optokinetic, it's initiated by the cerebellum. But as it goes through, that's what initiates the movement. We see this visual field, we send a message to our cerebellum that activates this nystagmoid movement and tells our brainstem to start making the eyes move in this fashion. And it's all the same circuit. It goes up the medial longitudinal fasciculus, and it goes up the brain, and it tells the internuclear bodies of internuclear pathways of the third, fourth, and sixth cranial nerves, which are the three cranial nerves that move the eyes, how to move the eyes. And we're not going to dive into exactly how to break down every eye movement in this video, but I will do that in the future for those of you that need it. So what we've done is essentially midline cerebellar tests of the inner ear to the cerebellum out to the eyes, which is the VOR. The COR is neck receptors to the cerebellum to the eyes, which is the COR. The optokinetic, which is visual field information to the cerebellum and back to the eyes to give you nystagmoid movements. And those are all cerebellar based movements generally. Now, the vertical component of movements, if we do up and down movements like this, right? I showed you before this kind of thing, but I didn't show you a lot of vertical eye movements. Vertical eye movements are more the mesencephalon drive those, but it's a little too advanced for this group. So let me just unpack the basic eye movements, and then we can dive into much deeper about which muscle moves the eye in which place, because I do want to do that for you. Our next eye movement is called pursuits. So we've done VOR, COR, optokinetic or OKN, and now we're doing pursuits, the fourth kind of eye movement. So a pursuit is again driven by the cerebellum largely, although the parietal lobe does contribute to this. And these are relatively slow eye movements that track a moving target that's moving steadily. And it can move across the visual field. It doesn't really matter what direction. I'll explain directions in a minute, but it's essentially like watching a bird fly across the sky or a plane fly across the sky. And so your eyes, and you can't fake a pursuit because you need a target. So if I were going to try to demonstrate it for you without a moving target, I would give you a bunch of saccades, which are fast movements like this, because I'm just looking from thing to thing as I try to mimic what pursuit might look like. But if I give myself a target for you and I share it with you, which is this pen, and I do let me do this a little easier for you to see. If I use a target like this, the tip of this highlighter, when I track it, now it's very easy for me to track that target, and you can see my eyes move very, very smoothly. Now, when any of these eye movements break down, it's a problem with the processing in the brain. And so when you see a breakdown of the normal eye movements in the VOR, the COR, the optokinetic, or the pursuits, now pursuits will look like, instead of a smooth movement, you'll see little saccadic intrusions, which means you get little fast eye movements in the middle of the movement. So the eyes go chirk, 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 instead of, it should look very, very consistent and smooth, just like a gun turret in a tank or a hunter that's tracking a bird. The movement should be very, very smooth. And if the eyes skip and get jerky, that's called a saccadic intrusion or a breakdown of pursuits, and that's a cerebellar sign of dysfunction. And typically, the cerebellum is involved in these movements for horizontal and diagonal movements, and for vertical pursuits, they are more likely if I'm just following a vertical movement. So it would look like this. The assessment would look like this. And it would look like this: diagonals, up, right, down, left, up, left, down, right. That's how it's done in the clinic. Fairly fast, but not terribly fast. And then up and down is vertical. Now, the up and down one is midbrain or mesencephalon does that. The diagonals, up, right, down, left, down, right, and horizontal are largely done triggered by the cerebellum. The difficulty with these is you have to look for smooth eye movements, and you have to go fairly fast. If you go too slow, you'll get an artificially smooth eye movement. You need to have quite a bit of excursion. You need to have quite a bit of speed as you go. It needs to be challenging. Now, when we do therapy, when we do pursuits as a therapy, we slow them down and we narrow the range. So the pursuit range might be only this far, and we might give micro pursuits as a rehab. So someone might need pursuit therapy. So they might have to do a micro pursuit of a horizontal like this, very slow, very slow. And very often, one of the things you'll see is a head movement intrusion. The person, if they somehow internally sense without consciousness that they're not tracking, they'll use their head and they'll look like a cat instead of using their eyeballs. This is an entirely eyeball movement. There shouldn't be any head movement at all. So sometimes you'll find that you have to hold their head or they have to hold their head still while they do this tracking, this pursuit. And you'll see that there's, you might feel that their neck is trying to pull their head, and that's them trying to cheat involuntarily. It's just a natural reaction if you have poor pursuits. The saccades are going to be the last for this video because it's getting rather long. And the saccades are fast eye movements where you jump from one target to another. Now, when you jump from one target to another, you don't see in between those, you don't process your visual information. You literally turn off your visual fields while you're jumping from target to target. So if you give somebody two targets, like I've given myself my two thumbs, and I go back and forth, those are called saccades. And you can do them fast and you can do them repetitively. Your patients will probably have difficulty with that because the left frontal eye field drives the eyes to the right, and the right frontal eye field drives the eyes to the left. It drives them away from the side. And those frontal eye fields are roughly in the area of F3 and F4 electrodes for your neurofeedback and your QEEG's 1020 placement. The saccades are a frontal lobe function. Now, obviously, the stoppage of all eye movements is done by the cerebellum, but the initiation of the saccades is unique because all the other ones we've talked about are either cerebellum or midbrain. Cerebellum or midbrain. If it's vertical, it's midbrain. If it's horizontal or diagonal, it's cerebellum. No matter what the origin of the signal is, whether it's the inner ear, the neck, or the visual field, it always goes through the cerebellum or the mesencephalon. Saccades are voluntary and conscious. And especially when you ask someone to actively pursue, you can't do this in your sleep, obviously, because they won't respond. But if you have them go from thumbnail to thumbnail, they'll go back and forth, and you'll note if they're accurate, if they're slow, if they can continue it, or they fatigue. So that's a way to assess the frontal eye fields and see how they're doing. So that's a lot for now, but we've got VOR, COR, optokinetic, pursuits, and saccades. And next time we will do other things like anti-saccades, convergence and divergence, and we'll also explain more of what the cerebellum and the semicircular canals contribute to these and how they're wired. Thank you.